So at this point, I'd like to introduce Dr. Karen Boyer, who's going to be presenting some student poster awards.
Good afternoon. Today we've witnessed the amazing work of our poster presenters, the young scholars, as Dr. Warren says. The students have done an excellent job in preparing and presenting their work. They have shaped and developed their ideas into research projects that will help us understand and work more effectively with minority elderly populations. These students are following research practices and shaping ideas that will make a positive and lasting impact in the field of science that supports minority elders and healthy aging. It gives me great pleasure to award the poster presenters for this year's 2018 Public Health Ethics Forum, Minority Elders and Healthy Aging. 6 abstracts were accepted as a response to a call for abstracts. We're giving awards to the 3 top poster presenters. These 3 recipients are also eligible to publish an article in the Tuskegee University National Center for Bioethics in Research and Healthcare, Journal for Healthcare Science and the Humanities. The poster presenters are Danielle McDuffie from the University of Alabama, Lane Doan, Oregon State University, Nguyen Nguyen, am I pronouncing your name correctly? Okay. University of Minnesota, Eugenia Stevenson, University of Maryland, Baltimore County, Kamara Briscoe, Tulane University, and presenting together were Yolande Petty, Interdenominational Theological Center, and Ashante Ali P. Davis, Tuskegee University. As I call your name, would you please come up to the podium? The first place winner is Nguyen Nguyen.
That's great. Thank you.
Thank you for your excellent work. Congratulations.
Thank you.
The second place winner is Kamara Briscoe. Kamara, would you come up? Thank you. Third place winner is Lan Dong. Would all 3 of you please come up so we can take pictures? Over here, go over there. And now, would the other 4 students please stand up? Congratulations to all and best wishes for much continued success. And thank you. And I would like to really thank you for answering the call of abstracts and coming here to CDC because you didn't have to do it. That was a tremendous job that you did with the poster presentations and also in submitting the abstract to us. Thank you so much for being a recipient here and for wanting to come here to be with us today. Congratulations to the 3 presenters who were first, second, and third place. Thank you, and would you all please give them another applause?
Now I'd like to ask Dr. Warren to come forward, who is going to be introducing our closing plenary speaker.
Organizing a poster presentation anywhere for anybody is a tremendously difficult job. And Dr. Karen Boyer has done it every year and has done an outstanding job. So I think we ought to thank her for her job well done. I have a tremendous bias about elders. You picked it up by now, I hope. The older you get, the better it gets. And so I want to have you listen to somebody that's getting better and better and better. Our speaker that closing plenary is a colleague who I've known for many, many, many years. And every forum where there was issues impacting upon health of people, particularly people of color, our speaker was been there, not only there, but in the front, making noise, talking trash, having an impact. And I was in New York at an event, and she popped up and took me back 20, 30 years about some work we did many, many years ago. And we revisited our relationship, and every time I asked her to come, she comes, regardless. That's friendship. That's a commitment to a goal. So Captain Wilkins was going to introduce her, and we talked about it, and I said, yeah, go ahead. But then I thought about it. I said, no, I need to say that, because what I wanted to say, I said, and otherwise you wouldn't know. So the formal introduction is always formal, but I need to say that so you would know how much I appreciate and respect the work that Dr. Georges is doing. Dr. Georges was elected, and hear me clearly, by the board of AARP to serve as National Volunteer President of AARP. That's big. So before she even comes up, let's thank her for that. That's not a paid job. That's a volunteer job. A job you volunteer to work yourself to death. Everywhere, all the time, she shows up. And she'll serve from 2018 to 2020. The president's role is filled by an AARP volunteer who's also a member of the all-volunteer AARP Board of Directors. The primary duty, as I read, of the president is to act as a principal volunteer spokesperson and liaison between the board and those AARP servers and 50+ AARP members and volunteers engaging in all these groups to promote the mission and strategic goals of AARP. I had no idea how powerful AARP is until I hit 55 and they start sending me stuff, and I said, I ain't old. What are you sending me stuff for? And I read, and what they were doing was educating me as I began to age, really what I ought to be thinking about. Not only what I ought to be thinking about, but what the nation is doing on the things that I ought to be thinking about. She served on the board of the Black Women's Health Study and RAIN Incorporated. She's earned her undergraduate degree from Seton Hall University School of Nursing, an MA degree in nursing from New York University, and a doctorate degree in educational leadership and policy studies at the University of Vermont. She lives in New York. She's an outstanding scholar, and she's a friend. And I asked her to come, and she left someplace where she was speaking to go back to someplace else where she's going to speak. So Dr. Georges is a special friend, and I want you to welcome her to this forum. Dr. Georges.
When you've been in the trenches with somebody like Reuben Warren from, oh my God, it's been about 30 years, then you can't say no to him. But I want to say good afternoon, and I'm delighted to be here. I don't know how much more I could say about healthy aging than you've heard earlier today, but I'm always grateful to have the opportunity to talk to you about challenges and the opportunities of healthy aging and the contribution each of us can make to meet those challenges. So I hope that today I can offer you a useful perspective. I get to speak to you as a nurse, but also, as Dr. Rubin says, the National Volunteer President of AARP, a nonprofit membership organization that's dedicated to addressing the needs and interests of people 50 and older. We dropped it down to 50. I want you to know that AARP has been on a quest for greater healthcare security and economic stability for older Americans for 60 years. So the topics I'm addressing this afternoon are close to the heart of the mission of AARP. I'm going to be very brief in telling you about why you need to understand about AARP. AARP was created by a woman by the name of Dr. Ethel Percy Andrus. I never met her. She's been dead a while. I was not the age to have met her. But my understanding from the archives and our historians in AARP, she was a feisty, red-headed trailblazer who came from California. And she was the first of many things. She was the first woman high school principal in the state of California. That was before women could vote. And she had to retire because she had to take care of her mother. But the reason why she founded AARP was because of a friend of hers back in the 40s who had retired from the school system in the state of California and couldn't afford to live in anything but what looked like a chicken coop, a shack. In those days, folks didn't hold older people in high regard, and they did very little to support them. But she said, and she kept to it, she said, we live in a country where it's wonderful to be young. It's time we create a country in which it's wonderful to be old. And so central to that mission was to make affordable health care for retired teachers. That's how AARP got started, with retired teachers. But she believed that it was not just a moral sense, but a market sense to cover older Americans. She talked about resilience. She had resilience. She went to 40 insurance companies before one said yes. Because, then, as sometimes now, people fail to recognize the wisdom and the profit, key word here in this country, profit, of insuring older adults. So at the age of 74, she created AARP 60 years ago. And I say to folks, I'm proud to be taking over in 2018 as the national volunteer, president of AARP, because guess what? I'm 74 years old too, so I feel great. So today, we have 38 million members. That's not something you ignore. Offices in every state and territory, and a huge array of programs aimed at helping older Americans and their families. So when she envisioned a society in which AARP helps all Americans to live with dignity and purpose. So that's where we've been for all these 60 years, in the pursuit of health security, financial resilience, and a vibrant life for each of us through all our life stages. This country was just getting used to the idea of a future in which more and more older people would live for years after they stopped working. I heard somebody says, I think it was Dr. Liebert, we went through stages. Well, that's out the rent. You know, we don't talk like that anymore. Because what people thought about retirement was having some old cranky old woman in a rocking chair whining and complaining about everything. You know, people thought 65 was old, and old age was a liability. And you know what? When you became 65 in this country, you couldn't be employed. Nobody wanted to hire you. They still don't in many instances. And you couldn't buy auto insurance. The idea that people might live to be 100 was seen as science fiction. But hasn't things changed? Isn't it remarkable here in the United States of America? We are in the midst, I'm supposed to be using this thing, I guess, of a titanic change. In this population that will make our world look like a totally different place. For those of you who've traveled to the Asian countries, you know, you'll see that Japan, China, Korea, the old of the oldest, I mean, in their population. In 2014, anybody who wants to admit to being a baby boomer, you can say, all right. But in 2014, the youngest baby boomers turned 50. They are the end of a generation that's 78 million strong. Don't you think that's power? And we've learned wherever they go, they change the landscape. Look at the Congress of the United States, your state Senate, and everything. They're not 25-year-old, they're 50 plus. Also in 2010, in the United States, 82% of all centenarians, I just thought I'd put that in, are women. By 2030, the number of older adults in the United States will nearly double, and 1 in 5 Americans will be age 65 or older. And the fastest growing age group, folks, in this country is made up of people 85 and over. We saw Attorney Segarra this morning. We saw the rest of the panelists. 10,000 people are turning 65 every day in this country. The actuaries at Social Security say that 1 in 4 of those people will live beyond 90, some of them for many more years after age 90. So today, a child has a better than 50% chance of living to be 100. I have a grandson. He might live to be 100 if anybody puts up with him that long. We might have 1 million people age 100 or over by the year 2030 in the United States. In fact, experts are now saying that the child who will live to be 150 years old has already been born. And I heard Dr. Hutchins talk about if we change and behave ourselves a certain way, we could optimize our life and live to be 120. Well, these kids born today can be 150. And hopefully they'll take on today, and our new slogan in AARP, take on today and live life differently. So in many ways today it's wonderful to be old in this country. Many older people are having the time of their lives. Ms. Clemens told us about that. She's 101 and she's living her best life. So much of what affects health and well-being are socially determined. And there are other things like poverty, food insecurity, smoking, drugs, homelessness. And we know that social determinants are the unmet social needs that can lead to the preventable conditions. I think I moved ahead. No, right. So we have got to look at the differences in the distribution of the social determinants, the influences of those social determinants. And remember that any one of those social determinants can block individuals from getting what they need. In AARP, we, along with Robert Wood Johnson Foundation, like to say that we want to create a culture of health that's enjoyed by all. And to do that, we have to address the social determinants of health and the disparities and inequities in our society that are lowering the quality of life for people in this country. So AARP and AARP, our foundation, have become ardent partners in wrestling with the social determinants that affect our health status. The diseases and chronic conditions that can result from poor social conditions are costly, and they're really public health challenges. So just think about it. How do you take a walk after dinner or visit a friend in some of our cities in this country if it puts you at risk of becoming a crime victim? How do you feed a family a nutritious meal in a neighborhood that has no grocery store and no fresh produce? The social determinants open our eyes to the conditions in which people are born, in which they grow, in which they live, and in which they work, and also how they age. It enables us to see the connections and the causality that many times can be easy to miss. So from this vantage point, health takes on a more expansive meaning than healthcare. We're looking at unemployment, substandard housing, crumbling neighborhoods, and food insecurity now becomes health issues. What if in our debates about healthcare, we grappled not only with a critical question of coverage, but if we looked at quality and affordability with the social factors that so clearly affect health? Again, these various social factors roll up into one main determinant. And in this country, we call it poverty. But see, poverty is not only an issue for individuals, it's a problem for society. Poverty is a societal illness. Do not blame the individual. It is not an individual problem, even though some folks feel individuals should be able to make choices. That may be true. But it's not an individual failure. It's a systemic problem. It's also corrosive. It's expensive. Anybody ever heard of payday loans? Just ask somebody when we say poor, they're going to work every day and they're borrowing against their paychecks just to avoid another cycle of evictions or to make sure they have food. So we know that poverty feeds on itself. And we know that poor women, I mean, this is unbelievable, that poor women, and you folks should have the data better than the rest of us at CDC, that poor women who undergo breast cancer treatment are 4 times more likely to lose their jobs than high-income women in the same situation. And that's in America. So I'm just going to offer you a couple building blocks. Oh, I said I went through the social determinants. But anyway, just a couple building blocks. And I think you heard some of this earlier today that I think we all need to engage in. If we're going to do something about these factors that influence minority elders, and also to make sure that we can age gracefully and have good health in the United States. So the first element is having an integrated perspective. I think we talked about that earlier. So we need to recognize and understand all the interrelated factors that can send a vulnerable older adult into a terrible downward spiral. When we do so, when we think in a holistic way, and I heard somebody mention holism earlier today, we're in a much stronger position to work towards permanent solutions, rather than simply intervening among a torrent of problems. The second building block is strengthening social connections. Now, we're talking about social connection of the old-fashioned kind, the real, person to person, not FaceTime, not Zoom, not Blackboard Collaborate, all that, Twitter and all that. So we're talking about not virtual or anonymous. But for older adults in this country, the person-to-person interaction is decreasing. And many older adults are paying a steep price for that decline. So we must deepen our understanding of the cause and the consequences of social isolation, folks, and the related issue of loneliness among our older adults in this country. We've known for some time about isolation's profound negative effects on health. The striking and urgent fact we now have uncovered is that isolation and loneliness are as bad for our health as smoking. One study shows that the health risks of prolonged isolation by older adults in this country are equivalent to smoking 15 cigarettes a day. Another shows that isolation and loneliness are worse for our health than obesity. They shorten life and make us physically and cognitively less healthy. Social connection, on the other hand, we found to contribute to resilience, the kind of protective shield against adversity. We also have mounting evidence to show that isolation and loneliness drive up healthcare costs. And, I don't know if I live in New York City, in the Bronx, where there's 1.3 million of us. And in the emergency rooms, when people keep coming in, we say, she's lonely again. Their best friend becomes 911 because there's nobody else who notices them. And so this kind of use of those ancillary services put a strain on our already almost unsustainable system in many of our cities. And then in addition, there's a connection between income and loneliness. Now, don't misunderstand me. Not everyone who is socially isolated is poor. And not every poor person is socially isolated. But it's clear that income is a significant factor in social connectedness and overall happiness. I'm waiting to get rich, Dr. Warren. But we need to recognize the effects on social connections and the interplay of housing and health and nutrition and transportation and income. But we must also build a greater understanding of how much we all lose when we effectively subtract from our communities the knowledge, the experience, the perspective, and talents of so many older adults. The third building block, you could make a strong case and said it should have been first. It's active listening. We need to resist the easy assumptions about the circumstances, the perspectives, and the preferences of those who are the most vulnerable in our society. You know, these assumptions, folks, are condescending, they're counterproductive, and they're isolating. We need to practice active listening and resist the easy assumption about what motivates people and what they want and need. You asked a question this morning that I was whispering before Mr. Segarra answered, when you asked about what should you do with your parents. And he said, listen. And that's exactly what we need to do. We need to listen to the older adults telling you what they need, not what we want for them. So if we have these preconceived notions, they will keep echoing in our heads. And guess what? They deafen us to the real issues that older adults are facing. So listening with intent can guide us to answers. It puts us in a place where we're totally committed to understanding what's going on. It also leads us to test our assumptions, and those assumptions can lead to innovations, folks, that will help us to drive our work. The fourth one is agents of opportunity. There are individuals and organizations or professions that are already primed to help. There are many of us who are willing and we're ready to be out there. In many cases, you'll find they've already been helping many of our older adults in communities across the country. But in other cases, we need to find and leverage those agents of opportunity and not confine ourselves to the usual suspects, because they're always working in what we can predict, places that we know. So remember that agents of opportunities will be those who are willing and they are eager to look at problems from new perspectives. Let me give you an example. In Philadelphia, there were a chain of supermarkets that took an innovative approach to provide access to benefit programs and nutrition services right in their store. They did something different. They brought the nutritionist and the dietitian into the supermarket. See, it was an old problem, but it took a new look at it. And they asked different questions. This is saying to us, we need to rethink some of the, approaches and strategies that we're using. So, agents of opportunities are all around us. The only limit is our imagination. And the final building block is collective impact. Now, I'm saying impact, not collaboration. The best way to solve problems is through each of us adding our strengths and multiplying those strengths to generate a whole that's greater than the sum of its parts. This is collective impact. It goes beyond collaboration. Collective impact raises the bar, and it reverses the issues our older adults are facing. We need our combined strengths to address a problem this big. So, guess what? Collective impact requires us to put aside our institutional ego and adjust some of the ways in which we have become comfortable in doing things. Yes, it's going to require compromise. Now, I'm not here to beat up on CDC, but that don't mean CDC don't know everything. I know you guys do caregiving, but guess what? You know who the biggest folks in caregiving today? AARP. We know what's going on out there. So all of us can give up our ego and begin to look at working together. We need to get out of those silos. You know, that's where we're so restricted in our thinking. And it also limits our capacity to join with other people in solving our problems. But if we use collective impact, it brings us into a shared space. You know, when we have collective impact, we affirm the uplifting of partnerships in translating good ideas into effective social policy. So we proceed from the understanding that no single policy, program, or group can solve a complex social problem by itself. So these building blocks have to rest on a strong foundation of smart and compassionate public policy. That includes an equally smart and compassionate federal budget. Let me just remind you that empathy is not a sign of weakness. It's a moral compass, and it's a moral compass that is a sign of strength. So in these divisive times, when it seems we're devolving into us versus them, it's critically important to recognize there's no them, there's only us. We're all bound together. We can't wall off the problems if we don't work together. So let's move beyond the scapegoats and let's begin to look at some solutions. And I think I have some solutions here. On one hand, we need to begin to look at creating a culture of care for our communities of color. One of the things that is very clear is that we have underrepresentation in clinical trials, which gets worse as you get older, because older adults are not included in clinical trials. The other issue is, you know, it looks great in this room, but those in the health professions, you know, people of color remain underrepresented. And then, of course, there's the overall unconscious bias that exists. We don't like to talk about it. It's always the 800 gorilla in me. But I can say it. I can get away with saying a lot of things. So I'm going to say it is what it is. And we see many times that we get into situations where people, particularly older adults in this country, are subjected, and if they're people of color, they're subjected to the unconscious bias and sometimes conscious bias that remains with our health professionals. So, I'm looking at a time, so what is AARP's goal? Well, one, you've heard us say, and we will continue to say to you, we're here to disrupt aging. We're here to disrupt aging. And if you don't believe that you are disruptors, then something's wrong. To disrupt aging, AARP is here to shake up the negative attitudes about people over a certain age, whether it's directed from the outside or worse, where it's self-inflicted. I tell people how old I am. I don't say I'm old. I just said, this is my age. And in the old Calypsonian verse, age is just a number. There's a growing body of evidence that says ages, attitudes have measurable negative health effects on older adults. And they certainly erode the confidence and self-esteem of older adults in this country. We in AARP are determined to shatter all those old stereotypes and spark new solutions around the idea of aging so that each of us can choose to live our lives in the most fulfilling manner possible. If we have another 35, I don't know if I want to have 35, but maybe 35 to 40 years to live, how can we make those years all we want them to be? So we're talking about the new normal. And the new normal for us is preparing individually and as a society, which to us it can be exciting and to some folks it's scary. It's about moving away, Dr. Liebert, from that three-stage life school work, and retirement. We're saying, that is not the new normal, to a more flexible one. And this new lifetime also comes along with challenges. For starters, not everyone has an equal chance to live longer, let alone capture the associated opportunities. So AARP wants to make sure that everyone has equal access to resources. We all need to live longer, healthier lives. Because you know what? Longevity is a huge gift. So we're going to need help to make that happen. So there are a couple things that we're doing. One is creating more what we're calling age-friendly communities. And in age-friendly communities, we're looking for 8 domains of livability. So if we want to be age and be in a healthy state, we have to have easy access to outdoor spaces. We have to have safe, affordable, convenient transportation. We need to have housing choices. We need to have social participation and civic engagement, since we're not going to just retire and, dry up or have our brains turn to mush. We want programs that promote ethnic and cultural diversity. We want opportunities for work and volunteer activities. We want to help people to use technology. And if you know anything about AARP, we run all those technological programs across the country, all our states. You got a great state, folks, here. You just go into AARP, Georgia, and you'll find those sessions. And we want to make sure they're community services. The other thing that AARP is doing is through our Living 100 project. Ms. Clemens, I'm giving your name to the state of Pennsylvania AARP. And in this project, AARP seeks to spark a conversation. How can we challenge our own mindsets and attitudes about aging? What do longer lifespan really mean for current and future generations? How can we address the disparities? These are the questions we're raising right now. The disparities in race and in gender and in income and in education and geography. That can be a matter of life and death. Because, we call it disparities by zip code. So it's simply, that's what we're trying to look at. And most of all, how do institutions and systems need to change so that we are not only living longer, but making the most of our extra time? So, folks, we have the power to help. Dr. Ethel Percy Andrews fought hard to change minds and to create a new reality. We're still facing many of the same battles that she faced. Sometimes we seem to be fighting over and over again. But we have the opportunity to create a new culture, a culture in which it's going to be wonderful to be young, and it's also going to be wonderful to grow old. But we can only do that if we, and I'll leave you with a poem, if we act as one, and if we believe in each other. However, we have to be committed to excellence, and we have to do whatever it takes. We have to embrace this common vision of healthy aging in this country. We have to foster the group intelligence to make it happen. We have to harness the power of the many here. But we have to inspire cooperation, not competition with each other. We have to juggle the skills and the talents that we have. But we also must kindle that collective impact and collaborative genius. We have to always look out for each other. And we have to engage in more of the we and less than the me thinking. We must not mind who gets the credit, folks. We've got to overcome the obstacles together. We have to put our principles before our personalities. But we have to quickly resolve any differences among us. We have to recognize each other's strengths, but we also have to share the workload. We must remember to treat each other with respect and utilize everyone's skill. We must value everyone's input. We must continue to work side by side, expecting exponential results. Well, we've got to yearn to succeed together and then to be zestful about making a difference. Thanks for inviting me.
I know you have some burning questions, so let them be heard and she can respond.
Yes, sir.
I want to thank you first for your inspirational words. And I, as a diversity and inclusion foot soldier that has written several strategic plans here at CDC and other organizations, one of the things that I'm seeing in the goals with AARP that I'm seeing is missing, and I was wondering if you could talk about that, is, and we talked about this when the President Obama implemented a diversity and inclusion executive order for the federal government, and that is the sustainability piece. How do we sustain what you and AARP, what many others, I believe, are working on trying to achieve in recognizing our aging population, which is part of our diversity and inclusion work that crosses all groups? I want to hear more about what do you see are the things we need to do to sustain the current work and to go higher?
One, we need to step out of our boxes. And one of the things I think, and when you think of when and how AARP was founded, sometimes we forget about the history. But we get so boxed into how and what we're doing. The points that I made about stepping out and looking for new partners is critical. You know, we seem to forget that people spend most of their time in community, not in coming to visit us in our institutions or coming to ask us for things, but that it's in the community where those deep roots are, and we've got to tap into them. So for us in AARP, one of the things, we have a whole multicultural leadership unit now. where we're digging deeper and deeper into those communities and developing partnerships with those, not the usual suspects, but those other organizations that are critical for the life of the communities that work to make sure that our older adults remain healthy and can age in place in their own communities. They don't want to be in no nursing home. They want to be where they're comfortable. So we've got different kinds of partnerships with the Hispanic Latino communities, with the Asian Pacific Islanders community, with African American, Black communities, with the faith-based communities. We're doing all different kinds of things. We have what we call pop-up events all over the country so that we may appear at some, you may call it a health fair. I don't believe in health fairs, but that's my personal view, but that'll be another discussion. But they show up at things where the people who will be the connectors in those communities are. And I think that those of us in institutions and in professional organizations need to learn how to do that better. And you don't need to come to the Alicia Georges. You might need to go to Susie Jones, who's the lady down the street who everybody knows. And Alicia Georges can put you in connect with her, and so you can reach further and deeper into the community. It's going to take us a while, but we got 38 million members, so we got all these folks. But so our volunteers are also the unsung heroes because they come from those communities and they open the doors for us.
Yes.
Okay. I guess my question would be, maybe it's a philosophical one, but how is AARP dealing with the fact that when you're aging and going through life, sometimes with the way history is written or kind of recorded, it doesn't necessarily always include everything that's happened to people or people you're connected to? How are they reconciling that, given that promoting ethnic and cultural diversity is important, but oftentimes if that history isn't there or if it's not written in a way that's uplifting the community, it can be almost where there's no evidence, therefore we don't have data, therefore what can we do, if that makes sense. Given
You're a
that,
PhD student, you're a data analyst. I'm just being fun. We have a historian in AARP who does use some of the hard data that may be available. But one of the things that Lily has always said and others have said is that you need to go to the people and help people to record what it is that's important to them. So you'll find that there are a number of things on our AARP website where we have the members who are talking and people who are talking about what it is that's meaningful to them. So you'll find stuff around caregiving, where people are talking about what it means to have, who and what, in the whole caregiving, sphere. We've got folks, interviews with people, and we tap into all if you belong to the Divine Nine, groups where we're at all their conventions. We're at all the Asian and Pacific Islanders, convention, the Hispanic, celebrations, and the Native American, powwows, if there's some in some of the states. We're there, and there are people who have that information and who tap into those folks in those communities who have that information and who can then share it with other members. It's hard for us. I mean, we can't, gather the history and the information for everybody, but we make a concerted effort to get the data from the people who are the most closely aligned with the communities that we're working with. And some of us need to write a little more about what's going on. Read well, you're too young, but you can still get AARP, the magazine, and read my column. But that's the other thing that we do. In our AARP magazine, which is the most widely circulated one in the world. It's they've got lots of good things. There are always stories about what's happening. And in our bulletin, there's always stories. On our website, if you tap into each one of the states or the 2 territories, which is Puerto Rico and the United States Virgin Islands, my home, you'll find, where's Dr. Hodge? Yeah, where's Hawkins? Yeah, we're from the Virgin Islands. You'll find the information and stories that people are telling about what's going on with them.
Last question?
As Dr. Neil Shulman, I have to defer to him. He was one of the founders of the International Society on Hypertension in Blacks. So I go way back about almost as long as with you, Dr. Warren.
Thank you. This has been an excellent event, but I just wonder if, in an entertaining way, there could be a movie series titled Laughing with Seniors, where all these messages are gotten across to all age groups. And we had been involved in writing a book, a comedy about seniors, and I used to do senior presentations. But I think you would be a great actor.
Thanks, Neil. That's friendship, right?
You could write the script. But seriously, this is an excellent, excellent event. And we just have to get the attention of the population in the entire country. And AARP is an excellent organization. And the message you have is so powerful. And, everybody wants to live a long life. So I think it could be something that everybody would join together with. And with people here who are leaders, it could become a real popular series, just like Harry Potter.
Thanks, Neil. If you all didn't know that, if you've ever seen the movie Doc Hollywood, Neil Shulman was the one who wrote the book that became the movie Doc Hollywood. So with Michael J. Fox. So he knows about writing. I don't know about that stuff, Neil. But thanks very much for having me.
Hold 1 second. One small comment before we close the session out. Dr. George was a speaker at our annual Tuskegee commemoration, and all the keynote speakers, we gave them a special gift. We had some coins minted, Booker T. Washington coins minted. The only place you can get them is at Tuskegee if you've done something very, very special. And a few of you in the audience have done special things that have a coin. Well, Dr. George has got a coin, and she called me and said, well, my grandson, I liked the coin, so I gave it to him. And I got grandkids. I know when they ask for something, they get it. So I want to give her another coin, so she will promise me to keep it for herself.
Yes, she will not get this one. Oh, thank you. Thank you very much. Thank you.
We have a small token for you as well. Just whenever you think of, use this, you think of us.
Thank you, Dr. Leiber. Thank you so much. Oh, thanks so much. Thank you so much.
Okay. Well, for those of you who were here when we got started this morning, I promised you that this would not be an ordinary gathering of public health professionals. And I also promised you that it would leave a mark that you won't forget. And I believe that the planning committee, who I want to thank right now, I want to ask you to stand so that people can see you. Don't be shy. They have been working for 9 months to pull this day together and have done a phenomenal job. I also want to thank all of our speakers and discussants and everyone who is present, those who have been viewing by IPTV. There are literally probably a couple hundred people online who have been participating with us today. And I want to thank everyone who has been part of this year's Public Health Ethics Forum. I want to end by sharing, and it really just kind of reiterates much of what has been said today. I was introduced to a book this spring that has really been probably the most influential book that I've read this year for me. And the title is The Leading Causes of Life. You know, we talk a lot about the leading causes of death, particularly at CDC. We're steeped in death and risk factors for death and everything associated with preventing death. And our goal is to prevent death. And this book kind of answers the question of life, well, preventing death to live, and then what then constitutes the leading causes of life. And so I'm just going to go through them very quickly. And let me just say this book was written by Gary Gunderson. Many of you would know him if you've been involved with any faith health work. I first met him when he was at the Carter Center, and it's co-authored by his friend and colleague Larry Prey. So the first one is connection, and I don't need to say anything more about that because Dr. George has elaborated on that beautifully. The second is coherence, which is having meaning in our lives. The third is agency, and this is having our own personal sense of empowerment and actually being empowered and acting on things that are important to us. The fourth they describe as blessing, and this is being a blessing to others as well as allowing other people to bless us with any manner of goodness that they would, and grace that they would want to extend toward us. And the last is hope. And so I hope that as you all leave this gathering today, that you leave with much more hope, much more intention, just with much more energy to be part of creating and promoting the ethical practice of public health, and in this instance, as it relates to older adults and minority elders. So I want to thank you again, and I'm going to ask Dr. Warren to come forward, and he will have his words and give us the final benediction.
Two things. Captain Wilkins has been very intentional about us meeting weekly and coming up with measurable objectives and strategies every week. For the last couple of months, we've met every Friday to be sure this was a success. So I want to acknowledge him particularly for the work that he's done. And on another level, this was a scholarly activity. If you didn't feel like it, you just need to know that. You didn't have lectures, you had conversations. We had data. You didn't call it data, but we had information. We had lived experiences. This was a scholarly activity, and we were intentional about who could come in here because we had limited space. Anybody in the world could get online, but only a few could get in this space. But we want to share the good news with everybody. And so we publish every time we have this forum, we publish the proceedings and additional articles. And generally we have the forum in April and we publish in December. This time we have the forum in September, but we published it in December. That means the presenters have to move quickly because we have a peer review process that we must go through. And this also is open to the world for continuing education. We didn't realize that folk from the outside were getting online and getting credit for CMEs. All last year, I don't know the number, but it was phenomenal. And so we want to be sure that you can go online and get your CMEs if you so choose. And I've been reminded 10, 12, 13 times to be sure that everything that you're going to be challenged on, we say it. So it's one thing that you may not have heard clearly, but I want you to hear this clearly, and also as important as the coloring of America enhances, that in 2016, 23% of people aged 65 and over were members of racial and ethnic minority populations. It's important to have that number, but more importantly, to understand this place is changing. Like it or not, it's changing. So get ready or not. Really important. And not lastly, but let me close by saying Dr. Leandris LeBert has great courage to work with us down in Tuskegee, because we don't hold any punches. We may say anything that we believe to be true. And in these times, we have to be thoughtful. So I want to thank her again for moving forward thoughtfully. It was her thought to focus on the elderly. And when she mentioned it to me, I was all in, because she's talking about me. So we switched the dates to September, but we're going to have a publication, and we're going to invite you and others to publish. And you see the intergenerational connection. The young folk, the posters, they can translate them to a peer review article that will enhance their career. That's big. I had 3 or 4 degrees and out of school for a long time before I published my first article. And the best way into a doctorate program is the publication of a peer review article. If they didn't tell you that, I'm telling you. Get it in, we'll peer review it, and get it on. So again, I want to thank you. We started on time. If you look at the clock, we're finishing on time. It doesn't get any better than that. And we want to thank you again for being here, showing up, and showing out. Thank you so very, very much.